Well, welcome everyone, and thank you for participating in the first ASBMR clinical case workshop for 2022 on low bone mass and anorexia nervosa. My name is Subhashini Ramchan from Harvard University in Boston, and I'll be co-moderating today's webinar with Dr. Liesbeth Winter from Leiden University in the Netherlands. Before we get started, I have a few quick announcements. During today's webinar, all participants will be in a listen-only mode. If you have any questions during the presentation, please use the Q&A feature at the bottom to submit your question. And I'd like to encourage you to submit your questions as the presentation goes along, and we will endeavor to have all questions addressed in the Q&A session at the end of the presentation. Today's presentation will be available as a recording in the ASBMR Education Center. You will receive a link to this Education Resource Center, and that can also be found at the main ASBMR website. It is now my pleasure to introduce today's speakers, Dr. Pouneh Fazeli and Dr. Tania Amorim. Dr. Pouneh Fazeli is Director of the Neuroendocrinology Unit at the University of Pittsburgh School of Medicine and an Associate Professor of Medicine. She's a clinical translational researcher whose research program has focused primarily on studying women with anorexia nervosa and the hormonal adaptations that lead to profound bone loss in this population. She has performed clinical studies investigating therapies for the treatment of bone loss in women with anorexia nervosa and is currently investigating the effects of transdermal estrogen through an NIH-funded protocol. Clinically, Dr. Fazeli sees patients with pituitary disease in the Neuroendocrinology Clinic at the University of Pittsburgh Medical Center and is Medical Director of the Pituitary Center of Excellence at UPMC. She is a proud member of ASBMR and currently serves on the Diversity, Equity, and Inclusion Committee. Dr. Tania Amorim completed her Ph.D. at the University of Portugal and University of Wolverhampton in the United Kingdom. Her Ph.D. focused on understanding mechanisms of osteoporosis in premenopausal populations, and she joined Dr. Fazeli's lab in 2021 as a postdoctoral research associate. Dr. Amorim is currently investigating the effects of fasting on bone metabolism and understanding the health consequences of caloric restriction with a focus on both bone cells and bone marrow adipose tissue. She currently serves on the ASBMR Early Stage Subcommittee. I'd now like to turn it over to Dr. Fazeli and Dr. Amorim to begin their presentation.
Thank you very much for the introduction and for the opportunity for us to present today. We'll be talking today about low bone mass in anorexia nervosa. These are our disclosures, and we will start presenting a clinical case. So our case is a 30-year-old woman that presents osteoporosis. She was quite active. She was a runner. She was running 42 miles per week on average. She did have a tibial stress fracture, and her primary care physician referred her for a DEXA scan. Regarding her past medical history and surgery was unremarkable. She was on she was taking supplements twice per day of calcium and vitamin D, and she was also on oral contraceptive pill. So she's starting the oral contraceptive at the age of 17 because she had irregular menses. Her age at menarche was around 15 years old. She denied any gastrointestinal symptoms, but she was following a gluten-free and dairy-free diet, and she was monitoring her caloric intake using an app on her phone. Regarding family history, her grandmother had osteoporosis, and there was no case of celiac disease in the family. She was a graduate student in biology, no alcohol, tobacco, or drugs use. Regarding her blood pressure and heart rate was a little bit low, as well as body weight. So she had a BMI of 16.6, which is considered underweight. So her body was in general very thin, and she had lagunar hair on her arms. As I mentioned, she was referred for a DEXA scan, and this is her DEXA results. So she was scanned at the lumbar spine, and looking at the results, if we follow the IOF criteria for osteoporosis, which says that a T-score of below minus 2.5 is considered osteoporosis. So the T-score is usually used for patients that have reached the peak bone mass. And also the ISCD recommends the focus on the Z score for patients that have not reached the peak bone mass yet. And in this case, the society says that the Z score below -2 is considered osteoporosis. So in this case, in the case of our patient, regardless which criteria we follow, either the IOF or the ISCD, she is diagnosed with osteoporosis, and she has a total T-score of and Z-score of -2.9. She was also scanned for the hip, and we just focused on the femoral neck region, because usually if you have a fracture, that where the bone usually breaks. So again, regarding which criteria you follow, the T-score and the Z-score was below -2.5, which it's diagnosed with osteoporosis.
So we'll come back to this case at the end of the talk, but now I'd like to switch gears and talk about anorexia nervosa and how we define anorexia nervosa, because we suspected that the patient that Tania just described, even though she didn't carry a diagnosis of it, did have anorexia. So anorexia nervosa is a primary psychiatric disorder, and the Diagnostic and Statistical Manual of Mental Disorders 5th edition criteria define anorexia as a restriction of energy intake. And this can be either through caloric restriction, over exercise, or purging. Patients with anorexia nervosa also have an intense fear of gaining weight, and there's a disturbance in the way one's body weight or shape is experienced. Now, what's noticeably missing from this criteria is an absolute weight cutoff, but we generally think of individuals with classic anorexia nervosa as being low body weight, which is classified as a BMI of less than 18.5 kilograms per meter squared. In terms of the epidemiology of anorexia nervosa, the lifetime prevalence is quite high. It's up to 2% in women. And the usual time of onset is adolescence. And this graph, which shows the attainment of peak bone mass, shows how problematic it can be to develop a disorder of decreased nutrient intake during adolescence, a time when bone mass is being accrued. You can see that after about the age of 25, 30, peak bone mass is achieved, and then after menopause, bone mass decreases and declines. So if there is a disorder that disrupts the attainment of peak bone mass, this peak bone mass will never be achieved. Now, in terms of anorexia nervosa, one thing that I've learned in the last 10 years of studying this disorder is that unfortunately, it's very much a chronic disease. Now, this was a study done by Cameron Eddy looking at individuals with anorexia nervosa, which is the top line, and bulimia nervosa, which is the bottom line. And this was the probability of non-recovery years after diagnosis. And what you can see is that after 9 years of diagnosis, the recovery rate is only about 32%. So nearly 70% of women still have active anorexia nervosa 9 years after their diagnosis date. And after 22 years, that recovery rate is only about 63%. So for nearly half the women who are diagnosed with anorexia nervosa, nearly half of them still have the disorder 2 decades later. So what are the consequences of chronic starvation? So there are a number of medical complications that are associated with anorexia nervosa, including anemia, leukopenia, bradycardia, hypotension, and we'll focus on the most common medical complications, which are low bone mass. So 52% of women have a T-score of less than -1, which is the postmenopausal criteria for osteopenia. And an additional 35% have a T-score of less than -2.5. And 30% of women with anorexia nervosa report a history of a bone fracture. Now, importantly, a prospective study showed that there was a 7-fold increased risk of non-vertebral fractures in young women with anorexia nervosa as compared to normal weight controls. So this low bone mass is very much associated with an increased risk of fracture. So what causes the loss of bone mass in anorexia nervosa? So because this is a population who's not consuming adequate calories, one thought is it because they're not consuming enough vitamin D and calcium? And that turns out to not be the case. So a number of studies have looked at vitamin D intake and calcium intake. And this is one study that looked at adolescent girls with anorexia nervosa and found that the total intake of vitamin D is significantly higher in anorexic adolescent girls compared to controls. That's also true of calcium. So total intake of calcium is significantly higher in anorexic adolescent girls compared to controls. And a significantly higher proportion of adolescent girls with anorexia nervosa meet the dietary reference intake for calcium compared to controls. So it's probably not a deficiency of vitamin D or calcium. So what is causing this loss of bone mass? And I think to answer this question, we really have to understand how we survive starvation. So our environment of evolutionary adaptiveness was marked by periods of famine. And so we have evolved to develop adaptations to survive these periods of famine. So during starvation, the goals are to conserve energy and also to minimize energy expenditure on processes that are not critical for survival. So two processes that are not critical for survival are reproduction and non-essential homeostasis, which is IGF-1, something I refer to as IGF-1 dependent properties. So with respect to reproduction, functional hypothalamic amenorrhea is a means by which reproduction is shut down at the level of the hypothalamus during periods of stress or undernutrition. And this occurs through disruption of gonadotropin releasing hormone secretion. And leptin has been shown to be a potential key mediator. So this was very elegantly shown in a study by Corrine Welt and colleagues, and they studied a group of women with functional hypothalamic amenorrhea. So on the left, you can see the LH pulses of these women at baseline, and you can see that there's low amplitude, low frequency LH pulsatility, or even no pulses or apulsatility completely of LH pulses, and that results in amenorrhea. Now, they treated these women with recombinant human leptin, and you can see that after just 2 weeks of treatment with recombinant human leptin, there was normalization of LH pulse frequency and pulse amplitude, and a number of these women went on to have ovulatory menstrual cycles. Now, you might say, well, maybe these women gained weight in the 2 weeks between baseline and the time when their LH pulsatility was remeasured. Well, it turns out that that wasn't the case because a number of these women ended up losing weight, and we'll come back to that point. With respect to non-essential homeostasis, again, these are IGF-1 dependent properties. So what typically happens is growth hormone is secreted by the pituitary and signals the liver to make IGF-1, which is responsible for most of growth hormone's growth mediating effects. Now, in anorexia and in states of starvation, we have growth hormone resistance. And the reason for that is because growth hormone has another important property, and that is to allow us to survive periods of undernutrition and starvation. So growth hormone has lipolytic effects and insulin resistant properties. So growth hormone allows us to sleep through the night without needing to eat. So during a state of starvation, we want to exploit those beneficial effects of growth hormone. So we want growth hormone levels to be normal or elevated to help us maintain euglycemia, but we don't want to waste energy on maintaining bone mass and muscle mass and growth. So we want IGF-1 levels to be low. And so there's a state of growth hormone resistance, which allows us to maintain euglycemia, but minimize energy expenditure on growth. And this was beautifully shown in a 10-day fasting study where you can see that after about the first 3 days of fasting, IGF-1 levels fell to below the normal range. And you might say, well, how do we know that wasn't a growth hormone mediated decrease in IGF-1? So growth hormone levels dropped and IGF-1 levels also dropped. You can see that concomitant with this drop in IGF-1 levels, growth hormone levels were at first stable, but then started to increase during the fasting while IGF-1 levels continued to drop, showing this disconnect and this growth hormone resistance. And we've also studied whether we can overcome this growth hormone resistance in women with anorexia nervosa. So this was a 12-week study in which we treated girls and women with anorexia nervosa with supraphysiologic doses of growth hormone. Now, the doses of growth hormone that we used were about 6 times the doses that you would use to treat people with growth hormone deficiency. And you can see that despite these very supraphysiologic levels of growth hormone, IGF-1 levels didn't budge in response to very high doses of growth hormone. So this growth hormone resistance cannot be overcome just with supraphysiologic growth hormone. So the question is, do the hormonal adaptations to starvation contribute to the low bone mass in anorexia nervosa? And this slide shows the many hormonal adaptations, some of which we've already discussed, that are the hormonal adaptations to starvation. And let's start with hypoleptinemia, which we've discussed a bit. So leptin is a hormone that is secreted by subcutaneous adipose tissue. And because levels of subcutaneous adipose tissue are low in individuals who are starving and in women with anorexia nervosa, low leptin levels are a characteristic finding in anorexia nervosa. So the decreased fat stores lead to low leptin levels, and in this population, low leptin levels have been associated with low bone mineral density, as well as altered parameters of bone microarchitecture. And in women with functional hypothalamic amenorrhea, treatment with recombinant human leptin has been shown to increase markers of bone formation, including alkaline phosphatase levels and osteocalcin levels. So the question is, can we use recombinant human leptin as a treatment for bone loss in anorexia nervosa? And the answer is unfortunately not. And that's because, as I mentioned before, weight loss has been shown to be an important side effect of treatment. So in a randomized placebo-controlled study, 20 women with functional hypothalamic amenorrhea were randomized either to recombinant human leptin or to placebo. And 1 out of the 11 women who was randomized to recombinant human leptin lost 8% of her baseline body weight. And an additional 4 out of 11 required dose reductions due to weight loss. The women who were randomized to recombinant human leptin also lost significantly more fat mass than the placebo group. So unfortunately, in a population where low body weight is already a baseline finding, we can't use a treatment where weight loss is a side effect. So what about hypercortisolemia? So this is another characteristic finding in anorexia nervosa, and cortisol levels are higher in women with anorexia nervosa and girls with anorexia nervosa compared to normal weight controls, because there is hypothalamic pituitary adrenal activation in states of physiologic stress, and undernutrition is an important physiologic stress. Cortisol also importantly has counter-regulatory effects, which help us maintain blood glucose levels during periods of starvation. So not surprisingly, this is an important adaptation to undernutrition. And cortisol has been associated with low bone mineral density in anorexia nervosa. So this was a study in which they measured 12-hour pooled cortisol levels. And you can see lateral spine bone mineral density on the left and total hip bone mineral density on the right. And you can see the higher the levels of 12-hour pooled cortisol, the lower the spine bone mineral density and the lower the hip bone mineral density. So what about hypothalamic amenorrhea? So both the low leptin levels and the high cortisol levels disrupt gonadotropin-releasing hormone. And that disruption in gonadotropin-releasing hormone pulsatility leads to decreased gonadotropin release from the pituitary and hypoestrogenemia or amenorrhea. So amenorrhea, importantly, has been associated with low bone mineral density in anorexia nervosa, just as it has been in postmenopausal women with anorexia nervosa. So this study looked at duration of amenorrhea, and here you can see it's listed in years. And you can see the longer the duration of amenorrhea, the lower the spine bone mineral density in this population. So the question is, can we use estrogen as a treatment for bone loss in anorexia nervosa? And when we look at retrospective studies, there was a positive benefit of oral contraceptives. So women in retrospective studies, women with anorexia nervosa who are on oral contraceptives seem to have higher bone mineral density as compared to those who were not on oral contraceptives. But every single one of the randomized placebo-controlled studies that have looked at this in both girls and women with anorexia nervosa have shown absolutely no benefit to oral contraceptives or oral estrogen in this population. So this was one study by Ann Klebanski that looked at, you can see the white bars represent women who were randomized to oral estrogen, and the blue bars are the individuals who were randomized to placebo. You can see their initial spine bone density was similar in both groups. And unfortunately, at follow-up, which was a mean of about, or a median of about 1.5 years later, at follow-up, their bone mineral densities were also unfortunately similar. And you can see that bone mineral density at all time points in the individuals with anorexia nervosa was significantly lower than in normal weight controls. So the question is, why does oral estrogen not why is it not beneficial for low bone mass in adults or adolescents with anorexia nervosa? And the thought is because IGF-1, which again is already low because of growth hormone resistance in states of undernutrition, is further suppressed by oral estrogen in a dose-dependent manner. So transdermal estrogen doesn't have those same IGF-1 suppressive effects as compared to oral estrogen. So the question is, can physiologic transdermal estrogen be used to treat low bone mass in anorexia nervosa? And this has been studied in a population of adolescent girls with anorexia nervosa. So this was an 18-month study that looked at the effects of low-dose physiologic estrogen, which was predominantly transdermal in a population of girls with anorexia nervosa. So the black bars all the way on the left are the girls who were on placebo. The middle bars, or the gray bars, were those who were randomized to low doses of transdermal, or a very small subgroup was randomized to oral estrogen. And then the white bars are normal weight controls. And you can see after 6 months, 12 months, and 18 months, there was no change in bone density in the population who was randomized to placebo. But you can see that there was a significant increase in lumbar bone mineral density at all time points, and up to 2.6% increase after 18 months in the girls who were randomized to the physiologic transdermal estrogen. So the question is, can we extrapolate these data to adults as well? And the answer is unfortunately not. And that's because bone modeling and remodeling differs in adolescents compared to adults with anorexia nervosa. So adolescent girls have lower markers of bone formation compared to normal weight girls, but their markers of bone resorption are similar compared to normal weight girls. Whereas adult women, when you compare them to normal weight women, have lower markers of bone formation similar to the adolescent girls, but they have higher markers of bone resorption. So they're in a high bone turnover state. And why is this? Now, this takes us back to the graph where we look at bone mineral content and bone mineral accrual over the years. And you can see that adolescence is a time of bone accrual, whereas adulthood is a period of time where we are just trying to maintain bone mass. And so that probably is why there is a difference in bone remodeling in adolescent girls with anorexia nervosa compared to adult women. So in adolescent girls, there's an overall low remodeling state, whereas in adult women, there's a higher rate of remodeling, especially compared to adolescent girls with anorexia nervosa. So we decided to do an open label study in adult women with anorexia nervosa and studied a hormone replacement therapy dose of transdermal estrogen. And in this open label study, we found that it was a 6-month study. We found a significant increase in both lumbar and lateral spine bone mineral density in adult women with anorexia nervosa as well. Again, this was an open label study, so now we are doing a randomized placebo-controlled study based on these pilot data. And what about growth hormone resistance? So we've talked a little bit about growth hormone resistance and low IGF-1 levels in anorexia nervosa. And importantly, those low IGF-1 levels are associated with low markers of bone formation. So IGF-1 levels are positively associated with markers of bone formation. So low IGF-1 levels are associated with low markers of bone formation. And IGF-1 levels are also positively associated with bone mineral density in this population. So the question is, can we treat low bone mass in anorexia nervosa with recombinant human IGF-1? And this was a 9-month study which looked at recombinant human IGF-1 in a population of adult women with anorexia nervosa. So all the way on the right, the women all the way on the right were randomized to placebo. The women, the next bar over, were randomized to oral contraceptives. The third bar from the right, the women were randomized to just IGF-1, and all the way on the left, those women were randomized to both IGF-1 and oral contraceptives. And you can see that there was a statistically significant increase in spine bone mineral density only in the group who was randomized to both recombinant human IGF-1 with oral estrogen in combination. And it was about a 1.8% increase in spine bone mineral density after 9 months. So in adults, bone mineral density does improve with the combination of IGF-1 plus oral estrogen. And this was recently this was recently a study, similar study was repeated, and similar results were found in a population of adult women with anorexia nervosa. So what about adolescents? So we've talked about the differences in bone modeling and remodeling in adolescents, and this study was recently done in adolescent girls with anorexia nervosa, where they studied girls who were randomized just to transdermal estradiol. It was a dose of 100 micrograms of transdermal estradiol, and those are the gray bars on the left. And then the black bars are the girls who were randomized to both transdermal estradiol plus recombinant human IGF-1. And what you can see is a very different finding than what we saw in adults. So in adolescents, there was no added benefit of IGF-1 with transdermal estradiol. Now, there were some confounders in this study. For example, the girls who were randomized to just the transdermal estradiol did gain more weight than the individuals who were randomized to both. But you can see that there really was no benefit, unfortunately, found with the combination as we see with adults. So as you can see from this slide, many of the hormonal adaptations that help us survive starvation also contribute to the low bone mass that we see in anorexia nervosa. And the question is, are there other factors that are also contributing to low bone mass in anorexia nervosa? And one of those potential factors is bone marrow adipose tissue. So bone marrow adipose tissue resides in the bone marrow compartment, and it shares a common progenitor with osteoblasts, the human mesenchymal stem cell. Now, most adipose tissue stores are not surprisingly lower in women with anorexia nervosa as compared to normal weight controls. So here you can see on the left, the subcutaneous adipose tissue, and on the right, the visceral adipose tissue depot. And you can see that women with anorexia nervosa have significantly lower levels of both subcutaneous adipose tissue and visceral adipose tissue compared to normal weight controls. But this is in stark contrast to what we see with the bone marrow adipose tissue depot, where levels are elevated in anorexia nervosa. So this is L4 vertebral bone marrow adipose tissue, which is measured by proton magnetic resonance spectroscopy. You can see that levels of the L4 vertebral bone marrow adipose tissue in the depot are significantly higher in women with anorexia nervosa as compared to normal weight controls. Similar findings have been shown in adolescent girls and also at the femoral sites as well. So this is what I refer to as the paradox of bone marrow adipose tissue. Why a lipid depot increases in size during a period of chronic starvation when we should really be using those lipid depots as an energy source is a paradox, and we really don't know the answer as to why this is. But we are trying to study bone marrow adipose tissue to understand why this is. And we do think that this might help us also understand the pathophysiology of bone loss in states of undernutrition. And why is that? That's because bone marrow adipose tissue is also inversely associated or negatively associated with bone mineral density. And this is not just in anorexia nervosa. This has been shown in many populations, including postmenopausal osteoporosis. So this is lumbar spine bone mineral density on the left and total hip bone mineral density on the right. And you can see that the higher the L4 vertebral bone marrow adipose tissue depot, the lower the spine bone mineral density. And when we look at the femoral metaphysis, the higher the levels of bone marrow adipose tissue in the femoral metaphysis, the lower the bone mineral density at the hip. So another question we had are, do potential treatments for low bone mass also affect the bone marrow adipose tissue depot? So the open label study in which we studied transdermal estrogen in a hormone replacement therapy dose of transdermal estradiol, it was an open label study for 6 months in women with anorexia nervosa. We did measure bone marrow adipose tissue as well. And what we did find was that after 3 months of treatment, there was significantly lower amounts of bone marrow adipose tissue at the L4 vertebrae compared to at baseline. There were also lower levels at the femoral sites, but these were not statistically significant. But it does suggest that the transdermal estradiol treatment also may lower the bone marrow adipose tissue depot. So we've talked a little bit about treatments as we've gone along through talking about potential mechanisms of bone loss in anorexia nervosa. So importantly, and what I want to stress is that there are currently no FDA-approved treatments for low bone mass in individuals with anorexia nervosa. And really the only option that we currently have for this population is recovery. So recovery of weight and menses is the most effective treatment for low bone mass in this population. And in women who recover both weight and menses, the mean annual rate of bone mineral density increases about 3% at the spine and nearly 2% at the hip. So this is really our best option at the moment. But as you'll remember when we were talking about the epidemiology of anorexia nervosa, unfortunately, this is a very chronic disease. And after 22 years, nearly 40% of women with this disorder still have active disease. So recovery is unfortunately not an option for all of the women. And so what can we do for the women who are not recovering to try to preserve bone mass and try to prevent fractures? So again, we'll review the treatment studies, many of which we've already discussed. So as you'll remember, for estrogen, it really depends on the route. So with oral estrogen, there has been shown no overall benefit to improvement in bone density with oral estrogen. But transdermal physiologic estrogen has been shown to be beneficial in adolescents with anorexia nervosa. So again, there was a 2.6% increase in spine bone mineral density in adolescents. And the jury is still out on adults. We are currently doing the randomized placebo-controlled study to try to definitively answer that question. With respect to IGF-1, so the benefit has been shown in adults and not in adolescents. So again, there was a 1.8% increase in spine bone mineral density after 9 months of treatment in adult women when it was combined with oral estrogen. And unfortunately, no additive benefit was found to transdermal estradiol in adolescents. With respect to testosterone, so low levels of testosterone are a characteristic finding in anorexia nervosa, and those low levels have been associated with low bone mineral density. A 1-year randomized placebo-controlled study studied the effects of transdermal testosterone on bone density in this population, and no benefit was shown. With respect to DHEA, which is an androgen precursor, low from the adrenal that is secreted by the adrenal glands, low levels have been shown to another characteristic finding in anorexia nervosa, and those low levels of DHEA are associated with both low bone mineral density and elevated markers of bone resorption. And a 6 to 12-month study showed no benefit of DHEA supplementation, but an 18-month study did show when it was combined with oral estrogen that there was maintenance of spine bone mineral density. Now, what about bisphosphonates? So bisphosphonates have been studied both in adults and again in adolescents. And in adults, a 1-year randomized placebo-controlled study did show benefit. So compared to placebo, there was approximately 3% increase in PA spine bone mineral density, and approximately 4% increase in lateral spine bone mineral density, and nearly a 2% increase in hip bone mineral density compared to placebo. But a study in adolescents showed absolutely no benefit of bisphosphonates in anorexia nervosa. And again, this is probably due to the fact that bone modeling and remodeling differs in these two populations. In adolescent girls, there's already an overall low remodeling state, whereas in adult women, there's a high rate of remodeling, which might be responsive to bisphosphonate treatment. So another question that has come up and is brought up many times is, should we even be using bisphosphonates in premenopausal women? And there have been a number of case reports and case studies showing that it may be safe, but because bisphosphonates reside in the bone for many years after their use, there is concern that in a premenopausal woman who later becomes pregnant, the bisphosphonates could leach out and affect the fetus. And lastly, what about teriparatide? So recombinant human PTH has also been studied in this population. So this was a study that we did in adult women with anorexia nervosa. It was a 6-month randomized placebo-controlled study. And you can see that there was a significant benefit in the spine. There was an approximately 6% increase in PA spine bone mineral density and approximately a 10% increase in lateral spine bone mineral density after 6 months of treatment with teriparatide. So of the treatments that have been shown to have efficacy, the question is which of these can be used long-term? And unfortunately, both with the bisphosphonates and with teriparatide, long-term use of these medications are limited. So with bisphosphonates, atypical femoral fractures have been associated with long-term use. And with teriparatide, it's not approved for greater than 24 months. So both of these potential treatments become problematic in a chronic disorder, which affects many women for very long periods of time. So now I will turn this back over to Tania, who will go back to our case.
Yes, so going back to our case, we had, just remember, we have a 30-year-old woman with a BMI of 16.6, so underweight. She was scanned with DEXA, and she was diagnosed with osteoporosis. She was restricting her diet, and she was over-exercising too. So she was diagnosed with anorexia nervosa too. And in this case, and follow our talk, what is recommended in this case and what we recommend for this patient was actually to stop the oral contraceptive. And the reason why, it's because with the oral contraceptive, she was bleeding every month, but it was not a real menstrual, so there was no benefit for the bone gain, so she couldn't gain bone mass following the oral contraceptive. So this is the recommendation: stop oral contraceptive. And so far what we recommend is focus on the weight gain, recovery the weight, so that eventually this, with a goal to recovery the menses. So as the talk highlight, if with the recovery of the menses, the bone mass will be also start to improve. So just to summarize our talk, anorexia nervosa is a chronic disease associated with low bone mass and a significant increased risk of fracture. Hormonal adaptations to starvation contribute to low loss of bone mass. And there is a challenging in the management of low bone mass in anorexia nervosa, and this is mainly for two reasons. One is there are differences in bone remodeling between adolescents and adults, and also there is a need for long-term treatment given the fact that anorexia nervosa it's a chronic disease. So right now in our lab, we're conducting a randomized placebo-controlled study where we are enrolling women with anorexia nervosa between the ages of 20 to 45 years old. One of the inclusion criteria is to have no menses, so amenorrhea, and we are also, all subjects will have a DEXA scan, so they can know their bone health status, and also vitamin D and calcium supplementation. So before enrolling to the study, our patients go through this screening, and we offer this DEXA scan, and then during 18 months, they will be either on placebo or having a transdermal estrogen patch. So the idea behind this study is to see the effects of the transdermal estrogen patch in bone, so to see if they can recover the loss of bone associated with anorexia.
Thank you, Tania. And I would just like to acknowledge members of the lab and as well as the collaborators. I'm no longer at Mass General, but I had a number of wonderful mentors and collaborators there that I'd like to acknowledge, as well as collaborators at other institutions, including Cliff Rosen, Mark Horowitz, and Orman McDougall, as well as the funding sources. So thank you. And we're happy to take any questions.
Thank you. Thank you, Dr. Fazeli and Dr. Amorim, for a fantastic talk. The session is now open for questions. Please type in your questions to the Q&A panel. We have a few. I would like to start with Dr. McClung's question regarding the low bone mass that you see in anorexia. And he wonders whether this is really due to bone loss or accelerated bone loss, or rather to poor acquisition of peak bone mass.
That is an outstanding question, and I think it is probably a combination of both. So I think in individuals who develop anorexia nervosa as adolescents, they don't achieve peak bone mass. There are women who develop anorexia nervosa as adults, and they do lose bone mass as adults with this disorder. And the problem is with the chronicity of the disease. If you develop this disorder as an adolescent, you never achieve peak bone mass. And there are long-term studies that look at women with anorexia nervosa, and very, very long-term studies show that a number of these women, even if they do recover, are at higher risk ultimately of fracture and of having osteopenia and osteoporosis as adults. But because they have this high state of bone turnover because of the disorder, I think there is also a continued loss of bone mass in adults as well. That's an excellent question.
Then following on from there, do you think that treatment should be tailored differently to people who are develop anorexia at different stages in their lives?
So I do think that is important. I do think that treatment should be tailored differently. For instance, if a postmenopausal, we do know that postmenopausal women have a high rate of developing anorexia nervosa. It was because the DSM-4 criteria included the development of amenorrhea as a criteria for diagnosis. I think it was diagnosed less frequently when we had the DSM-4 criteria. Now the DSM-5 criteria don't include amenorrhea as one of the defining characteristics of anorexia nervosa. So more postmenopausal women are being identified who have this disorder. I think if you identify it in a postmenopausal woman, options such as teriparatide become better options because the disease may have less of a chronicity, and you can use that option at a time when somebody is at very high risk of bone fracture. Whereas I don't want to waste my 2 years of teriparatide on an adolescent or somebody who is a young adult who has an overall lower risk of fracture. So I do think tailoring treatment to different periods of time is important. And I think the benefits of something that can be used long-term is such as transdermal estrogen in individuals who are amenorrheic. If that turns out to be beneficial, I think that is something that can be used chronically in this population. And we really need to focus on treatments that can be used chronically.
Thank you. So 2 questions that are related. One, I guess the majority of the studies that you have been showing us are based on bone mineral density by DEXA. And I have a question from Dr. Kohlmeyer that wants to know if there have been bone quality studies, such as using TBS or HRPQ-CT or biomechanical CT. And I guess in addition to that, my question is, in studies that use DEXA, are there any artifacts because of this low bone, the low weight rather, that then needs to be taken into account? And how do you go about interpreting your results in light of this?
Those are both excellent questions. And in an interest of time, I didn't highlight the bone quality studies, but there have been many studies looking at high resolution peripheral quantitative CT and peripheral quantitative CT in this population. And those studies do show that there are worsened or altered parameters of bone microarchitecture when they look at estimates of bone strength using a high resolution peripheral quantitative CT images and finite element analysis to estimate bone strength. Bone strength parameters are also lower in anorexia nervosa. So the bone quality studies do seem to support the bone density studies. So we don't think that this is an artifact. We do think that it's actual bone loss. Both excellent questions.
Dr. Winter, would you like to go through some of the questions?
Yeah, of course. Thank you. I would also like to ask, before we go to some questions with respect to radiology and immunity, I would like to ask with respect to fracture risk. If patients become in remission, how does this fracture risk develop? And is that mainly associated to their initial peak bone mass, or how is that?
That's an excellent question. And I think that does relate to Dr. McClung's question, the very first question. I think because the disorder tends to develop in adolescence, or its highest time of development is during adolescence, women never achieve their peak bone mass. And so this long-term fracture risk, even in people who go into remission, is probably due to the failure to ever have achieved peak bone mass.
And there was a question, thank you for that. There was a question from Marianne Shini to Tania Amorim. What would you have done if the BMD was a lot worse and decreasing in that patient that you showed? You need to unmute, sorry.
You're muted, Tania.
Sorry. So the question is what we have done if the BMI continue to, well, I think that the focus that
No, the BMD, the bone mineral density.
Well, the question, that's the challenge. I think that the longer it has exposed to anorexia, the lower the BME will continue to decrease. So this is why right now the focus should be on recovering the body weight. So slowly by recovering the body weight and eventually the menstrual, the BMI should go up slowly. But hopefully with the study that we are conducting right now in our lab, maybe the estrogen patch could be a solution. But right now it is just focused on the body weight and on the menstrual.
Thank you. And with respect to treatments, there is the question from Oliver Bock. What do we know actually about the role of sclerostin in bone pathophysiology in anorexia nervosa? And is there actually a difference between adolescent girls and adults? And could you imagine to use romosozumab in patients, well, mainly the adults in that case?
So that's an excellent question. So sclerostin levels do tend to be higher in anorexia nervosa as compared to normal weight in both populations. But we've looked at whether changes in sclerostin levels are the mediators of treatment effects. So in the estrogen study, we looked to see whether changes in sclerostin levels were associated with changes in bone mineral density, and we didn't find that to be the case. And I do think, so the question about romosozumab is an excellent question. It is, I think, currently being studied potentially at Mass General right now. So we'll have an answer as to whether it is efficacious. I do think, the challenge with this disorder is that it is such a chronic disorder. So you want to make sure that the treatments you use are used at the right time, which was one of the other questions. You want to make sure that you're using treatments when people are highest risk of fracture, if there's a limited time to use them. For instance, the teriparatide, we showed that there was a beautiful increase in bone mineral density in the spine after 6 months of treatment, but that's not a treatment I would use in someone who is young and has an overall low risk of fracture, because I'm gonna wanna save it for when she's older, and I only can use it for 2 years.
And in the older patients, what about intermittent teriparatide? That's the question following up on this from Pouneh.
Yes, no, that's an excellent question. We don't know the answer to that, but that is an excellent possibility, something that should be studied.
And we have another question also with respect to, well, maybe reverse the bad bone situation. That's a question from Lynn Kohlmeier. Can specific loading or back strengthening counteract some of the bone deficits in anorexia? And would there be a difference in bone mass between the anorectic swimmers or the runners, for example?
That's an excellent question. So most of the individuals that we see with anorexia nervosa do exercise, and many of them do. The problem is that they over-exercise. And so we do see bone, that they are loading their bone, but they still lose bone mass. And that is probably because of the negative energy balance, despite the fact that they are exercising, and you would think that would improve bone mineral density. And they probably do have slightly better bone mineral density at the weight-bearing sites than the non-weight-bearing sites. But because they're in an overall state of negative energy balance, it doesn't lead to beneficial effects on bone density.
And one more question on the energy balance. Actually, do bone cells have an energy sensing mechanism? That's a question from Sam and Kim.
That's a very good question. Tania is actually studying this in the lab right now, and she may be able to answer this better than me.
Well, so yes, I mean, regarding the energy balance, they do consume a lot of energy to function as well. So I do think that there is, they sense like the energy, but going back to the other question, and I just wanted that's exactly, and because I've seen it also, the problem is like the energy deficit, that when you exercise, you are consuming calories, the calories that these patients, they don't have. So that's why they don't have any beneficial. And of course, there is a cost by using your activity, because when you are exercising, you are stimulating your osteocytes. So this also requires energy. So yes, so I think that's not a benefit on this matter.
One more question, and then I would like to hand over to Dr. Ramchand again. That's a question from Stuart Weinerman. So there is, of course, always the problem that anorectic patients deny them being anorectic or having this caloric restriction. Would there be any utility of leptin as a diagnostic tool?
So that is an excellent question. And I will say that oftentimes I do two things when patients are in denial. One, I will order the bone density scan to give them something concrete to look at, even if they deny being anorexic. If their bone density is low, it gives them something to focus on, and we can talk about why their bone density is low. And I often do, when somebody is not admitting to the anorexia, I will measure a leptin level, because a low leptin level or a low normal leptin level does suggest low body fat stores and does suggest that that may be the cause of their amenorrhea. So it gives them something to focus on. So even if they deny the anorexia nervosa, we can say that even if you're not anorexic, at least your body is sensing that you're not getting enough energy and you're in a state of negative energy balance. So I think that that is an excellent suggestion.
Thanks. So I'm going to just take over for a few more questions, maybe starting in terms of chronological order from which they were submitted. The first question is from Alan Malabanan, and he wants to know, are women with anorexia at higher risk for atypical femoral fractures with bisphosphonates? And do you think this may be related to issues with IGF-1, if that is the case?
Yep, so that is an excellent question, and we don't actually know whether that is the case. I haven't seen data suggesting that they're at higher risk for it. But because they do have low bone density and it's chronic and it's a chronic disease, if people are treating women with anorexia nervosa with bisphosphonates, I assume they're treating them long-term. And so we may be able to see that data down the road.
Thank you. This is from Jonathan Trejo, says, thank you for the presentation, and wants to know if there are any studies looking at bone density in men with anorexia nervosa, given that you talked about the testosterone study in.
Yes, so that is an excellent question. There have been studies that have looked, Dr. Madhu Misra has done a number of studies in adolescent boys, at least, with anorexia nervosa, and they do have hypogonadism and lower bone density. I think the challenge with, just as in women who don't, and girls who don't necessarily admit to having anorexia nervosa, it can be even harder in boys and men who have anorexia nervosa, because we don't, at least in girls and women, we see them losing their menstrual cycle and their menstrual period, and they present to their physician potentially with amenorrhea. In men, hypogonadism is a much more complex diagnosis. It requires the patient presenting with signs and symptoms that need to be identified as hypogonadism. And so I think it is a much more hard diagnosis to make. And so the number of boys and men who are diagnosed with anorexia nervosa, even though the prevalence is probably not as low as we think it is, I think that it is unfortunately a harder diagnosis to make, and so it's a lot harder to study.
Thank you. And this question is, quite, I guess a lot of people in clinical practice will come across, in patients that do also require a method of contraception. What do you think are some of the optimal choices in terms of hormonal contraception?
So that's an excellent question. I will say that a lot of the providers who don't want to prescribe oral contraceptives these days are recommending non-hormonal IUDs to their patients, because that will allow the contraceptive method to be effective, but also to not mask whether or not the patient is having or recovering their menstrual cycle. Because I think, as Tania pointed out with our patient, we wanted to stop the oral contraceptives because oral contraceptives often give these patients a false sense of normalcy, that they think that they are having regular menstrual cycles, even though it's an artificial menstrual period. It's exogenous estrogen and exogenous progesterone that's resulting in the menstrual cycle. So I think something that doesn't cover up the amenorrhea is a good method of contraception, and I think the non-hormonal IUDs provide a good method of contraception. But if the patient is still amenorrheic, the hormonal IUDs will cause amenorrhea, and so that will mask whether or not the patient is recovering or not. And the non-hormonal IUDs don't.
And a related question, do you think the Mirena or Kylena IUDs affect bone mass?
I think they very well might. I think that even though the progesterone is only supposed to be locally available, I do think that in some patients it does get systemically absorbed and can shut down the hypothalamic pituitary adrenal axis. I've seen it in a couple of my patients in clinic. And so I don't tend to recommend that for the patients with anorexia nervosa, because I do want them to see themselves recovering their menses and their menstrual cycle. So I do recommend the non-hormonal IUD option, because that will allow them to have a menstrual cycle when they achieve recovery.
Shall I go on, Sabs?
Yes. Yes,
sorry, I didn't notice. Well, there is a question from Leptin Levels. What about the role of immunity and chronic inflammation in the pathogenesis in these anorectic patients?
I think that is a very, very important point. And we do think that there may be an immune response. Also, IL-6 may be a factor in low bone density in this population as well. So it's very, very possible.
And there is a question from Madhumati Rao about bisphosphonates. They remain the first-line medication that's used in the pediatric age group in other conditions with low bone density or bone fragility. If we would apply this rationale that remodeling is not prominent, should we be rethinking this?
I think that's an excellent question. I do think if in the other populations, I assume that we have studies that show benefit of the bisphosphonates, and in the population of adolescent girls with anorexia nervosa, there was no benefit to the bisphosphonate in the randomized placebo-controlled study that was done. And so I think it's very hard to recommend. That is the hypothesis as to why we didn't see benefit in anorexia nervosa, but we don't know for sure. So if there is benefit, then I do think that there is rationale to continue using the bisphosphonate in other potential populations. But in anorexia, the data hasn't borne out that way.
And a question from Christy Tauf. What is the mechanism for the increase in bone mass adipose tissue? Is this actually different from the increase in bone mass adipose tissue in other conditions like diabetes? And she would like to thank you both for this great informative lecture.
Oh, well, thank you. And that question is the $6 million question that we would love to know the answer to. What drives the increased bone marrow adipose tissue in anorexia nervosa? Tania is working on a study right now trying to understand hormonal mediators of bone marrow adipose tissue. And so I would love to know the answer to that question. We think that probably some of the same hormonal adaptations that contribute to loss of bone mass probably also lead to increased bone marrow adipose tissue, like the hypoestrogenemia, but we are still investigating. So thank you for that question.
And then we have a last question on the anabolic therapy again. Since the FDA label has changed, of course, would it be now something to consider to use the anabolic therapy longer in these patients? And another question about the dosing of the anabolics, but also of the bisphosphonates, of course. Might they be, do we need a reduction in dosage with respect to the low body mass of these patients?
Yes. So with respect to the anabolic therapy, it is something that still needs to be studied. long-term. So we did a 6-month study in anorexia nervosa, so we don't have longer-term data, and we didn't see improvements in hip bone mineral density, which is perhaps not surprising with teriparatide, but we used a standard dose. We used the standard dose of teriparatide. We didn't do any dose reduction. And the doses of bisphosphonates have been standard doses of bisphosphonates. So there have not been significant changes based on body weight.
And one last question, in postmenopausal women that were previously anorectic, could you just treat them with anti-resorptives as well, non-secondary osteoporosis patients, or would you recommend anabolic therapy?
So that's an excellent question. So, you know, and this goes back to Dr. McClung's initial question. So the women who have low bone mass postmenopausally but are recovered from anorexia nervosa are at higher risk of fracture and are at higher risk of having low bone density, but it probably has to do with the fact that they didn't achieve peak bone mass. And so, you know, do we know that, for instance, that those individuals, we don't suspect because they are in remission that they have a different pathophysiology than other postmenopausal women who are normal weight at that point in time. We don't think that there's a long-term effect. But so I think treating them as a normal postmenopausal woman with osteopenia or osteoporosis who is at risk of fracture is appropriate in that population.
Well, I would like to thank you both for this very, very nice lecture, together with the very nice discussion, for which I would also like to thank all attendees with the good questions, which made it a very vivid discussion, I would say. And also I would like to thank my co-moderator, Sabram Shant, for moderating. And then I would like to ask to set up the last slide, since we're closing this session now with respect to time, although we probably could go on with questions for a bit more time. But we have, of course, a next clinical case workshop for which I would like to invite you all. The date will be announced together with the speakers and the topic later this month, but it will be somewhere in March, so please note the emails. And thank you all for attending, and again thank you all for the thank you speakers for this very nice presentations.